Welcome everyone to Medical Grand Rounds at the University of Colorado. It's good to be back here in person in Troffel Auditorium. If you are not here today, please come in the coming weeks. I want to fill up the auditorium. As a little bit of a teaser for folks, next week we're going to welcome Dr. Trish Critic, who is one of my personal mentors. She's an incredible physician. She's the director of the Office of Faculty Affairs at the University of Washington, talking about career development and mentoring for clinician educators. And then on January 31st, we're pleased to present our own Dr. Hatim Sabawi, who's the Associate Director of Translational Research for the Division of Medical Oncology, talking about gene therapy and the intersection of personalized medicine. As a reminder, you can claim CME and MOC credit. You can go ahead and click on this link now. And then one other additional reminder, we're going to put this up for a couple of weeks in a row, but now is the time when we're looking for speakers for next year's Grand Round series. So please scan this link if you'd like to nominate a Grand Round speaker. They can be internal or external. These links are also going to show up in the chat as the talk goes on for folks that need a little bit more time to think about this in the coming weeks. Okay, now I am very pleased to welcome today's speaker, Dr. Connie Hess. Dr. Hess is an interventional cardiologist and an associate professor of medicine here in the Division of Cardiology. She is also a faculty member of the CPC Clinical Research, which is an academic research organization affiliated with, obviously, our own university here on the Anschutz Medical Campus. She did her undergraduate work at Harvard College, where she graduated magna cum laude. She was a medical student at Harvard Medical School. She was an intern and resident at the Mass General in Boston. She then went to North Carolina and was a fellow in cardiology and interventional cardiology at Duke University, where she also did a fellowship in clinical research, getting a master's in health sciences. After completing her training, Dr. Hess joined the faculty at Duke University as an assistant professor who also worked in the Duke Clinical Research Institute. At the DCRI, she participated in clinical trial operations for multiple cardiovascular studies. She served on the steering committee for the registry-based Safe PCI for Women trial, and also her work focused on improving outcomes for folks with acute coronary syndromes after percutaneous intervention. Currently, Dr. Hess's clinical interests are in acute and stable coronary artery disease, as well as vascular medicine. Her research is focused on modification of ischemic cardiac and limb-related risk in patients with atherosclerotic cardiovascular disease through medical therapies as well as device-based therapies. She's a consultant for the FDA's Cardiovascular and Renal Drugs Research Advisory Committee, a member of the American Heart Association, the American College of Cardiology, and the Society for Cardiovascular Angiography and Interventions. It truly is a pleasure to welcome Dr. Hess to Medical Grand Rounds.
Great. Well, thank you so much for that introduction, and thank you for the opportunity to speak here today. It's truly an honor. In terms of disclosures, I do receive salary support from CPC Clinical Research, and I'd like to just pause for a quick introduction here. For those of you that don't know, as Jeff said, CPC Clinical Research is a nonprofit academic research organization affiliated with the University of Colorado. We sit on campus. This is a picture. We're located in Bioscience 3. Would love for you to come visit. CPC was founded in 1989 by Bob Schreier, and then for more than 2 decades was run by Will Hyatt, really a giant in vascular medicine, who passed away almost 3 years ago now. The current director for CPC is Mark Banaka, another key leader in the field who's driven forward a lot of the science for how to treat patients with PAD. So no talk on PAD would be complete without referencing the contributions of these 2 important people. And I am fortunate and grateful to have learned under Will and to now call Mark my mentor. So without further ado, peripheral artery disease, or PAD, commonly refers to stenosis or occlusion in the aorta or lower extremity arteries. It's typically caused by atherosclerosis, and it can manifest several ways. For example, with exertional with exertional leg pain that is relieved by rest, that we call claudication. Patients can also have rest discomfort or tissue loss. And as shown in the bottom 2 pictures, sorry, I know you're eating. This is called critical limb ischemia or chronic limb threatening ischemia as a very morbid condition. On the right, I've just shown a picture of a CT angiogram depicting a patient with multi-level PAD. Now, unfortunately, the global prevalence of PAD has been rapidly rising. Between the year 2000 and 2010, you can see there was a 24% increase in the number of people living with PAD. The current estimate has more than 230 million adults with PAD worldwide. And part of what's driving this is an increase in the prevalence of risk factors for PAD, including obesity and diabetes. And now, when you look at the observed trends for these risk factors, such as obesity and diabetes, you'll see that they're actually driving an epidemiologic shift in PAD as well. Whereas the incidence for PAD has traditionally been highest in patients, in high-income countries, it's now actually shifting from high to low-income countries, which is important to note. Now, PAD is often described as a marker of systemic atherosclerosis. And this is a seminal publication put out by the ABI collaboration in 2008. It shows that there is an association between ankle brachial index, which is a measure of limb perfusion and a diagnostic test for PAD, and all-cause mortality. Now, when you look at patients with an ABI of 0.6 or less, you'll see that they have a fourfold increased risk of mortality. On the opposite end of the spectrum, patients with high ABI, so greater than 1.4, also have an increased risk of death. And this is because these patients have severe disease and calcified non-compressible vessels. Beyond mortality, patients with PAD are at risk for major adverse cardiovascular events, or MACE. These are typically defined as myocardial infarction, ischemic stroke, or cardiovascular death. And this is an important analysis from Dr. Banaka looking at the risk of MACE in patients with PAD compared with those with MI or stroke, but no PAD. And what's interesting here you see is the PAD patient actually is at higher risk for MACE than the patient who has had an MI or stroke. If you dig a little bit deeper here, you'll see that the highest risk group outlined in red there is actually the patient with PAD and prior MI or stroke. So we call this the polyvascular patient, the patient who has atherosclerosis in multiple vascular territories. Now, as illustrated here, this is a high risk group that we're talking about. And for many years, PAD was considered an enrichment factor in large cardiovascular outcomes trials. So if you wanted to increase your MACE event rate, you would include patients with PAD. It wasn't until more recently that clinical trials were designed for a primary PAD population and where people really started to focus on limb outcomes, which of course makes sense for patients with PAD. And here you see a nice illustration comparing cardiovascular versus limb outcomes in patients with PAD. And limb outcomes can include peripheral revascularization, lower extremity amputation, or acute limb ischemia. These are often collectively termed major adverse limb events, or MAIL. I didn't make up the acronym. I find it funny though. And what's important to see here is that that limb events really are the major dominant morbidity in PAD. So although there's been a lot of focus in the past on cardiovascular events, limb events really are equally, if not more important. And here's a nice demonstration of that. So this is a slide that Mark Banaka put together. I love the slide. He calls ALI, acute limb ischemia, a STEMI of the leg. Now, acute limb ischemia is a feared complication of PAD. It, like STEMI, is due to acute thrombotic occlusion of an artery. I see some of my interventional colleagues here in the audience, and so we like to use the adage, time is muscle. You'll hear us say that, and that's because outcomes are determined by time to reperfusion, and this is certainly true for acute limb ischemia as well. If you look at the bottom of the slide, you'll see that outcomes after an ALI are poor, and arguably worse after an ALI event than a STEMI. Now, if we think about who's at risk for acute limb ischemia, this is work that we did from the Euclid trial. This is a trial of ticagrelor versus clopidogrel monotherapy. It was led by Will Hyatt. It involved almost 14,000 patients with symptomatic PAD. This is actually one of the first analyses I did when I came to Colorado and worked with Will. And you'll see that in this patient population of patients with chronic stable PAD, 1.7% of patients had an ALI. And when we looked at factors associated, the factor most strongly associated with ALI was having undergone a prior peripheral revascularization. That was associated with a 4.7-fold increased risk of a future ALI event. And what about after the ALI event? Well, here you see poor outcomes again. So a 2.5 to 3.5-fold increased risk of MACE or all-cause mortality. Now, these are data, as I mentioned, from a population of patients with stable PAD, so not undergoing a procedure. But what happens if we look at the same scenario after a procedure? As you can imagine, when we do peripheral revascularization procedures to patients, we cause endothelial dysfunction and injury, activate platelets, activate the clotting cascade. So we looked at this also in patients undergoing peripheral revascularization. These are data from the Voyager PAD trial, which I'll go into a little bit more detail a little bit later. But there were 6,500 patients randomized. These are patients with symptomatic PAD undergoing peripheral revascularization. And here you can see that acute limb ischemia is actually the most common complication after a peripheral revasc. And in fact, the cumulative incidence here is 7.8% at 3 years compared to the 1.2 that you saw, much higher risk here. And again, after an ALI event, outcomes are poor. So patients had a 2.4-fold increased risk of all-cause mortality and a whopping almost 24-fold increased risk of major amputation. And major amputation for here is defined as at the level of the ankle or above. So not minor toe digit amputations, but really amputations that can affect quality of life and function for patients. So we further looked into the timing of risk for both limb and cardiovascular events. This is an analysis that I led using data from the Premier Healthcare database, looking at more than 390,000 patients with PAD undergoing peripheral revasc in the US. You can see here graphed in red is the risk for major adverse limb events. You'll see that time 0 is the time of the procedure, and the risk for limb events pretty much starts as soon as the procedure is completed, right? So the graph really goes up quite quickly. And yes, it does plateau as you get farther out from the procedure, but it never returns back to baseline. In contrast, when you look at the risk for cardiovascular events, such as myocardial infarction or stroke, that also increases from the time of procedure, but in a much more steady, linear fashion. So this here is important to just understand the risk associated with the peripheral revascularization event and also the timing. Now, when we think about the axes of risk that contribute to poor outcomes in PAD, of course, there are many. I'm not going to go over all of these, but I'm going to focus mainly on hyperlipidemia and atherothrombosis, which are two areas of particular interest to me. We start with hyperlipidemia. We know that the idea of LDL reduction and reduction in ischemic risk in patients, particularly with cardiovascular disease, is not new. We've known this for decades. And in fact, these are data from the heart protection study from 2007. Here we see that there also was a benefit for simvastatin versus placebo in reducing limb events. So a 16% reduction in peripheral vascular events and a 20% reduction in non-coronary revascularization. Now, more recent therapies have focused on targeting PCSK9. As many of you know, PCSK9 in the liver chaperones LDL receptors to their destruction. And so by inhibiting PCSK9, you increase the number of LDL receptors on the hepatocyte and decrease circulating levels of LDL-C. Now, this has become an important class of therapy. I'm sure many of you are aware of this and hopefully use it in practice. But this was an important trial, the Fourier trial, looking at evolocumab, which is a monoclonal antibody targeting PCSK9, versus placebo in more than 27,000 patients with stable atherosclerotic cardiovascular disease. These patients were already on statin therapy. Now, on the left, you'll see that evolocumab compared to placebo reduced LDL by almost 60%, highly statistically significant, very effective drug. On the right, you'll see that evolocumab compared to placebo also significantly improved outcomes and reduced cardiovascular events. In this subgroup analysis, Mark Banaka looked at the subgroup of patients with PAD enrolled in Fourier, and you can see that evolocumab not only reduced major adverse cardiovascular events, but also major adverse limb events. So lipid reduction here also works for limb events. And what's impressive is there was a 48% relative risk reduction. So a very robust benefit. And you'll also see that in blue, in the placebo group, there was a very high event rate, right? So again, as we talked about, high baseline risk and therefore high potential for benefit with therapy. Now, this is a different trial looking at alirocumab, another monoclonal antibody targeting PCSK9. Odyssey outcomes, you may be familiar with this. This was led by our very own Greg Schwartz, Chief of Cardiology at the Rocky Mountain VA here on campus. Another important study, this one looked at a patient population with recent ACS, so recent acute coronary syndrome, so a little bit different than Fourier, but very similar results. So when you look on the left, you'll see that alirocumab versus placebo significantly reduced the risk for MACE, particularly in patients with polyvascular disease. That's that top set of lines in green. And then on the right, again, a subgroup analysis showing that in patients with PAD, alirocumab also reduced major adverse limb events. Now, this is an important graph here showing the relationship between reduction in major adverse limb events and achieved LDL-C. You can see that this is a linear relationship. And in fact, the relationship holds even down to very low levels of LDL-C. So important take home from here is that lipid-lowering therapy reduces bad limb events. Lower LDL-C is better, and there's really no too low, right? So what do our guidelines say? This is a busy slide, but some of you may be familiar with this already. I wanted to just quickly review the current US and European guidelines for cholesterol management. On the left are the guidelines from the US. You'll see, I'll just summarize really because you can't read that. But in patients with very high risk atherosclerotic cardiovascular disease, the US guidelines recommend a threshold for either initiating or titrating therapy with lipid lowering agents of 70 milligrams per deciliter. They recommend stepwise titration, starting with statin at maximum tolerated doses, and then addition of ezetimibe and then PCSK9 inhibitor. Now, on the right are the guidelines from Europe, and they are more aggressive. They recommend a target of 55 milligrams per deciliter or less, and at least a 50% reduction from baseline. But what's happening in practice, right? So how has this how are we adopting this in practice? Well, not very well is sort of the short answer. But these are data from Lisa Colantonio looking at patients with atherosclerotic cardiovascular disease in the US. You can see they looked specifically at statin use and categorized any statin use versus high intensity statin. On the top row is the highest risk patient with 3 involved vascular beds. So the polyvascular patient, and you'll see only 57% are on any statin therapy, and less than a third are on a high intensity statin. So pretty abysmal. But wait, it gets worse. When you look at the bottom row in black, this is the patient with PAD alone with no coronary disease or prior stroke. And only a third of patient is on any statin therapy. So really not doing well here. Now, our group looked at this as well, but we went a little bit further and in fact looked at 250,000 patients with PAD in the US. These are market scan data. We looked beyond just statin therapies, but also looked at non-statin therapy use. So ezetimibe, PCSK9, and you can see that in blue, at baseline, 40% of patients were on no lipid lowering therapy. So even worse than what we saw before. Now, what we did was we categorized lipid lowering therapy into different strategies of intensity. So, for example, the high intensity group involves either high intensity statin, combination therapy, or use of PCSK9 alone or in combination. And you'll see that 21% of patients at baseline were on something called, something that could be considered high intensity. We followed patients and there was a median follow-up of approximately 18 months. And you can see over 18 months, almost no change, which is quite depressing. And in fact, the no treatment group went up a little bit. Now, beyond just using and prescribing meds, what we're really looking for, as I showed you, is achieved LDL. So we looked at almost 19,000 patients in this analysis who did have LDL values available to really understand what are we doing in terms of achieving our goals. This is a distribution, a histogram just showing the baseline distribution. You can see that the median LDL-C in this group was 91, so well above either US or European goals, less than a quarter of patients at goal. And what happened over approximately 18 months of follow-up? Well, maybe a small shift down. So the median is now 86, but still we're not where we need to be. So here I think we have a clear problem. We know patients with PAD are at high risk. We have data with proven efficacious therapies, but we're not using them. So how do we bridge the gap in translation of evidence from clinical trials into clinical use? This is sort of the key question, right? We're generating all this evidence, but how do we get people to use it? And this is where the discipline of implementation science really comes into play. So implementation science is defined by the NIH as the study of strategies to adopt and integrate evidence-based health interventions and change practice patterns within specific settings. So in other words, implementation research seeks to understand factors that impact sustainable adoption of evidence-based therapies, right? So these are things like understanding provider behavior, what motivates patients and policymakers, how do healthcare systems work, how can we tweak them locally in a local environment, right? So I'd like to show you an example of an implementation study that we designed and conducted here at the University of Colorado. This was the Optimized PAD-1 study, and these results were actually just presented this past year. I presented them at the scientific sessions of the American College of Cardiology, and we've submitted the primary results for publication. They're currently under review. In Optimize-1, we enrolled patients with vascular disease, namely PAD, who either had an unknown LDL within the past 12 months or an LDL-C not at goal. We drew screening labs, and for those who were at goal, great. We followed them in a registry. Unfortunately, most were not. And we enrolled and randomized the patients who were not yet at goal to 2 different arms. So one involved provider education and usual care. The second was called the vascular care team arm. All patients actually met with a vascular medicine provider, underwent cardiovascular risk assessment. And for patients assigned to usual care, those patients received their primary providers and or primary vascular providers received a consultation note, including copy of the lipid guidelines, recommendations for medical therapy changes that were recommended by the vascular medicine specialist. But then that was it. Then they were left to kind of usual care. For patients in the vascular care team, they actually had their lipid management taken over by a multidisciplinary team involving the vascular medicine specialist, involving, the clinical nurse, and then also a clinical pharmacist who really took over a lot of the ownership in terms of checking repeat lipid panels, titrating medications. And the selection and titration were actually all done according to an algorithm that was designed to achieve the lowest LDL as quickly as possible. Okay, so, and just to finish up on the schema here, the primary endpoint for the study was % change in LDL-C from baseline to 12 months. Now, this is a copy of the algorithm that we used, that we designed for the study. And you'll see that it actually, it helps you select the class of therapy for upfront prescription. And it does account for both the patient's baseline LDL-C as well as their current therapy. So for example, highlighted here, you'll see this patient comes to you statin naive, but their baseline LDL is 180. So rather than stepwise titrate and start a high intensity statin, then add the ezetimibe, those are not going to be effective. So for this patient in this study, we actually just started right off the bat with statin and PCSK9. Okay, why wait? So here is the consort diagram for this study. We enrolled 166 patients locally from our clinics here. You'll see, as I mentioned, almost 3/4 were not at goal for LDL-C. There were some that screen failed for the reasons in the top right. We ended up randomizing 114 patients to the 2 arms that I described. 5 patients did not receive the vascular care intervention, but there were 0 patients who withdrew consent, no patients lost to follow-up, and everyone was included in the primary efficacy analysis. without further ado, here are the primary results. So in blue are the patients treated by vascular care team, in orange, usual care. At 6 months, you'll see a 47% reduction in LDL-C with vascular care treatment, and this persisted over time, compared to an almost 9% reduction in the usual care with a little bit of regression to the mean. And by 12 months, which was the primary outcome, only 5%. So significant reduction and significantly different. If we look a little bit more closely at the temporal trend, draw your attention to the orange line first. This is the usual care group. They started with a baseline of 106 milligrams per deciliter, dropped to 93, and then again, that regression toward the mean that we saw by the end at 97. But contrast that with the blue line. So started at a baseline of 101, and by 4 weeks, the mean LDL-C was already less than 55, so less than the European threshold of 55. And that really persisted and in fact continued to downtrend a little bit. So, pretty impressive. I think I'm a little biased, of course, but pretty impressive in terms of the results and the timing and what we were able to achieve. And how did we do this? Well, when you look at the types of lipid lowering therapies that we were using, it wasn't really the statin. I mean, when you look here, there is a slight increase in high intensity statin in both groups, but this wasn't significantly different. It actually ended up being use of non-statin therapies such as ezetimibe, such as PCSK9 inhibitor. And so really what we're talking about is combination therapy. And so I think this is important here just to also highlight that just being on a statin is not enough for these patients. This high-risk group requires combination therapy. So just something that, we learned here in this study as well. And so finally, when we think about achieved goal LDL-C, you can see that at any time point, 6 months or 12 months, using any threshold, 55 or 70, patients in the vascular care team were much more likely to achieve their LDL goal than patients in usual care. And I would like to point out that one important factor here to keep in mind is that medications for Optimize were provided through standard insurance and payers. We didn't actually provide free drug for anyone. So, as the prescribing provider, I would prescribe, for example, as one of the doctors, Mark Vanaka also saw patients, but, we prescribed these medications and then we sort of let the patient, percolate through with the pharmacist's assistance. So the pharmacist, of course, was very helpful with prior authorizations where needed, where to answer any questions about drug interactions or side effects, things like that. But this, I think, is really key because with implementation, you need to think practical, right? It needs to be pragmatic and able to be done in practice. So Optimize, I think, was a great example locally of how we really can improve care for patients with PAD. We can achieve LDL goals if the systems are enabled to do so. Now, I'd like to shift gears just a little bit to talk about another important concept here with implementation, and that is the concept of when to switch therapies, timing of when to intervene. Now, I'm going to draw your attention back to this analysis from our group that I did show earlier. And this is the patients with PAD in the US, how are they being treated? How effective is their lipid therapy? Well, we were interested to see, does anything really drive change, right? So over the 18 months of follow-up, what might or might not drive change in therapies? And so when you look in blue, you'll see the baseline status, 25% of patients on a regimen that would be considered high intensity. And then over follow-up, if a patient had no clinical event, so that's the no event group, there really was no change, right? 26% of patients on a high intensity regimen. However, if patients had, for example, an admission for critical limb ischemia, that's CLI, if they had a major adverse limb event, I'm sorry, I didn't realize things were cut off on the bottom, but I'll tell you what they mean. So if they had a major adverse limb event, you see that there is a step up in therapy. So providers took notice when patients had events and did increase therapy. Now, of course, when you look on the last column, you'll see the patient who had an MI or an ischemic stroke. Providers took the most notice after that. And that, again, just highlights that PAD continues to be undertreated even relative to other atherosclerotic diseases. But the important point here is that an acute event is possibly a time for change, an opportunity to really strike. Now, this concept's not really new, right? We've seen it in the coronary space. These are data from just excerpted from a large body of literature supporting use of dual antiplatelet therapy after percutaneous coronary intervention, after acute coronary syndrome. We know that DAPT works. It reduces stent thrombosis and reduces recurrent MACE. In practice, it turns out we've been able to adopt this. Right, these are data from more than 10,000 patients admitted with ACS around the world in Europe and Latin America. When you look at their discharged antithrombotic use, 8.9% are on single antiplatelet therapy, but 85% are on DAPT with another 5% with an indication for oral anticoagulation. So it can be done. We can translate data into practice. We just have to think carefully about how to do that. Now, what's happening in the PAD space? Have we been able to see this implementation? Well, I would say the most related kind of analogous situation in PAD here, and particularly with antithrombotic therapy, relates to a strategy called dual pathway inhibition. You may be familiar with this. This involves, the dual refers to inhibition of platelet activation using low-dose aspirin, as well as inhibition of thrombin generation using low-dose rivaroxaban. This regimen was very well studied in the COMPASS trial. For those of you that remember or don't remember, COMPASS studied more than 27,000 patients with stable atherosclerotic vascular disease, most of whom had CAD, but 27% had PAD. They studied 3 separate regimens, so rivaroxaban 5 milligrams twice a day alone versus rivaroxaban 2.5 milligrams twice a day plus low-dose aspirin versus low-dose aspirin alone. And as you can see from the graph here, the low-dose rivaroxaban plus low-dose aspirin regimen significantly reduced the primary outcome of MACE versus aspirin alone. And in a subgroup analysis, there was also a significant reduction for major adverse limb events in the PAD subgroup with this regimen. So this trial was actually stopped early for efficacy. That doesn't happen frequently, but it was, and the FDA gave an indication for use of what we call vascular dose rivaroxaban in patients with PAD based on COMPASS. Now, this was in 2017. That was when COMPASS was published. And what about patients undergoing peripheral revascularization? Recall I had alluded to the Voyager PAD trial. Well, this was another trial studying that same low-dose rivaroxaban plus aspirin versus aspirin alone. And 6,500 patients with symptomatic PAD undergoing both surgical or endovascular or hybrid peripheral revascularization were enrolled. Patients were randomized to rivaroxaban 2.5 milligrams versus placebo, and then all patients received aspirin. And they were allowed to receive clopidogrel for a certain amount of time. The primary endpoint for Voyager was quite unique. I'd like to just point out, again, in the space of focusing on PAD, it not only included MACE, but it included acute limb ischemia and major amputation of vascular etiology in the primary outcome. Really quite novel, had not seen this before. And so when you look at this graph, you'll see a very early separation of curve and of the curves, and you'll see that rivaroxaban significantly reduced the primary endpoint at 3 years. The hazard ratio was 0.85, and again, very high risk group. And so there was an absolute risk reduction at 3 years of 2.6%. So a number needed to treat only of 39. And notice that the curves, as I said, do separate early, so there's benefit early upfront. Now, I should mention, based on Voyager, there actually was an expanded indication given for use of vascular rivaroxaban in patients with PAD undergoing peripheral revascularization. But what are we doing in practice? Again, let's take a look at we see the data generation, but then we need to look at what's happening. These are data actually from Mario Canonico, who's sitting here in the audience. He's one of our faculty cardiologists at CPC. He looked at data from our own University of Colorado system, right? So this is us, this is me, this is my colleagues, all of us. More than 10,000 patients with PAD who were treated after Voyager was published. And you can see in purple is the vascular dose rivaroxaban combination dual pathway inhibition. Only 6% of patients are on it. So not great, very low overall use. But what's interesting is when you look at the right, you will see that actually there's 2.6-fold greater usage for this regimen in the setting of patients undergoing a procedure, undergoing a peripheral revasc, compared to sort of a chronic outpatient who happens to have stable disease, right? So again, another lesson for implementation, just showing that the setting matters, the clinical setting matters, and an acute event or an acute procedure may be really a time to kind of strike. Now, this is really the fundamental concept underlying the Evolve-MI study. Some of you may be familiar with this, but Evolve-MI stands for evolocumab very early after MI. And now this is a study, it's a collaboration between the US, Brazil, and Sweden. CPC Clinical Research is actually leading this study. Mark Banaka is the operational PI. I'm the national lead investigator for the United States. And in Evolve-MI, patients who are hospitalized with NSTEMI or STEMI due to atherosclerotic plaque rupture are randomized to evolocumab given within 10 days of the index MI plus routine clinical care versus routine clinical care. We're expecting to enroll about 6,000 patients. The primary endpoint is a total events endpoint, so includes MI, ischemic stroke, any arterial revascularization, all-cause death, so total events, including recurrent events. And we're expecting this to last for a median follow-up of about 3.5 years. Now, it's a very pragmatic study. I'll kind of describe it in case you see patients that would fit, please reach out. Very pragmatic, so type 1 MI, there's no inclusion criteria that requires a minimum LDL. They don't have to be on a maximally tolerated statin. Again, we know lower is better, just give it, right? So that's what we're really testing here. Additional pragmatic features include data collection through the electronic health record, patient surveys, and then in Sweden, as many of you may know, they have very, very good registries in Sweden, national registries, mandatory participation. So we're able to extract data from there as well. Now, we're hoping with Evolve-MI that the study design will prove this idea, as I mentioned, of just adding an effective therapy. Don't titrate, that just adding works. Getting the LDL-C lower faster is actually better than sort of this, long tail of titration. And we want to prove that we can do this in practice, that this is a feasible approach. As you've probably seen, we're looking to overcome clinical inertia. We want to strike at a time when, providers are already reassessing medications. Patients are, quite frankly, scared and vulnerable, and they're open to changing therapies and behavioral changes. This is an ongoing trial right now. Recruitment has been extremely rapid. I will say with unprecedented rates of enrollment. We are one of the top enrollers at the University of Colorado. I certainly hope, we'll continue that. And if you see patients in clinic or on the wards and you see the term Evolve-MI, now you know what it means. And so this is really exciting, I think, for all of us here as a pragmatic implementation study. Now, an additional rationale for striking at the time of an MI is actually that's the time of greatest risk for the patient. Right. So in addition to everything else I've shown you, this is an analysis from Fourier. It's a subgroup analysis that included patients who were enrolled who had had a prior MI and for whom they knew the timing of their most recent MI. And you can see graphed here the risk of the primary endpoints, the risk of cardiovascular event according to time, as a function of time. And you'll see that the risk is actually highest in that circle. So i.e. closer to the time of your MI, right? And conversely, when you look at the potential benefit for your therapy, the hazard ratio for effect of evolocumab also was actually lowest the closer you are to your time of MI, right? So another way of looking at this is essentially graphed here. This is another slide from Mark. When you look at the risk profile after an acute coronary syndrome, you'll see again in red, the time of greatest risk is upfront, right after your MI. The farther out you get, the lower the risk gets, which is great. But then when you contrast that with the traditional titration approach for lipid lowering, which is graphed on the bottom, you'll see there's really a mismatch, right? By the time you get to your most intensive therapy, combination therapy, that's the time of lowest risk. So what we're looking to do here is to change the paradigm for how we're treating these patients and really match treatment with risk. Now, we're not the only folks who believe in this approach. This is a consensus statement, an expert consensus statement that came out of Europe. It was published in 2022. And I showed it because I liked their little phrase, strike early and strike strong. You know, I think that's a great way to think of this, to really try to match treatment to risk. And as I kind of close up, I'd like to bring it back to kind of come full circle and bring it back to PAD. You know, I showed you this graph from our data showing that peripheral revascularization, which is an acute event akin to an acute coronary syndrome, is associated with high upfront risk, particularly for limb events. And I've shown you that lipid-lowering therapy works. So having shown you the schema for Evolve-MI, I'd like to put forth the next frontier, Evolve-PAD. And so here, I think if we can really adopt the same paradigm and test it rigorously with a pragmatic implementation study in the same way that we are doing for MI, I think this will really be of great benefit for our patients who we know are at high risk. So I'd like to leave you with a few concluding remarks here. Patients with PAD are at high ischemic risk, particularly for limb events. Efficacious therapies to reduce cardiovascular and limb events do exist, but remain underutilized in patients with PAD. Acute events are opportunities to strike early and strike strong. But we're going to need implementation science to increase adoption of evidence-based therapies in clinical practice. Thank you for your attention. Happy to take any questions.
Dr. Hess, thank you very much for that talk. If you all would take your phones out, please. We need some evaluations. We've done this for 3 weeks. We've gotten a total of 3 evaluations so far. So if we want to keep getting MOC credit, we're going to have to do a little bit of work here. And while you're doing that, I appreciate it. We'll take questions for Dr. Hess from the audience. And while folks are doing their phone work, I'll start off with one and I'll take the mic back here. Can you talk about taking the optimized endpoints that you've looked at out further, 6 months and 12 months? Obviously, I think the question is like, what happens to patients at 3 years, 5 years? Are you all doing that with your data set, or is anyone else doing that?
No, that's a great question. I think, Jeff, you're getting to this idea of sustainability, right? Sort of, we can make changes, but are they really any good if we can't make sure that they're in place and sustained? So, we are following these folks. I had alluded to a registry. So we will be continuing to look and see what happens, longer term. In addition, we're also interested in clinical outcomes, right? So LDL sort of as a surrogate for benefit, the cholesterol trialist collaboration, sort of from that, we know for every millimole per liter reduction in LDL, we attribute about a 20% risk reduction for cardiovascular events and mortality. Based on the results that we saw in Optimize over a 5-year period, we would expect about a 22% reduction in these ischemic events, but we certainly want to see, does that happen? Is that what pans out? And so we will be following them in a registry, but great question. Thank you.
Hi, my name is Gus Ruckman. I'm one of the third years in the MedPeds residency. And first of all, thanks for wonderful grand rounds. I share your interest in implementation science. I'm curious if the results or if the kind of program design from Optimize has actually been carried forward in your practice group. If the answer is no, I have another question.
No, great question. Currently, as I said, we are still awaiting publication of these results. We haven't implemented it yet in practice. I mean, I think the idea would be, of course, to show that it works, to disseminate the results. But a lot of implementation, as you know, is based on sort of local practice. And so, we're certainly interested in, can this work in other healthcare systems? Can this work in other disease states, for example, diabetes, hypertension, things like that? But within even our own group, we definitely want to see if we can get support from leadership to, sort of build this program. I think if we you make the case that we're going to improve outcomes, we're going to improve compliance, things like that. I think we can make the case. There certainly is going to be investment up front in, for example, having a clinical pharmacist who's available to help with this. But I do think at the end of the day, the offset will be worth it.
So that kind of is my second question. There are so many wonderful implementation science trials out there, and usually the intervention is more expensive for the practice group or the institution than usual care, which is nothing, daily life. And so even if you can demonstrate clinical efficacy for patients, and even if you can demonstrate cost efficacy in terms of like global healthcare dollars, given our kind of US different payer models, those healthcare dollars have to come from somewhere, right? So you may be saving an insurer, a payer, or a patient dollars in the long term, but you may not be saving an institution that's hosting a practice group dollars. And so how do you think about then really like socializing and disseminating and ultimately like making your business case for putting implementation science results into like broad institutional practice?
Yeah, no, that's a great question. I think, what you've pointed out, first of all, is it's complicated. There are a lot of different actors and a lot of different payers and different groups and interests. And to be frank, I do still think that even, you had said, even if it is cost effective, it'll be hard to move. I think that's true, but I think if it is cost effective, we will be able to move. At the end of the day, money will drive a lot of this. And if you say, we're able, yes, it costs money to have a pharmacist in clinic. It costs money to have, the vascular medicine specialists involved and to have this multidisciplinary team. But think of every admission that you're saving, right? I mean, admissions for the MI, for the stroke, for the peripheral revascularization procedure, the procedural costs, none of that is cheap either. And I do think at the end of the day, if you can actually show, unfortunately, in hard numbers, which often drives behavior at sort of more institutional levels, I think if we can do that is how we're going to need to go in a location by location sort of first step. It's almost a grassroots type of thing. I think if we were to sit there and think we're never going to change anything, why would we try? So we really have to have sort of a more grassroots approach here. And I do think that's actually also important because what happens at the University of Colorado may be different than what happens at Vanderbilt or at Mass General, or, so I'm not going to purport to know exactly what you can achieve in other systems, but I do think showing we can do it ourselves is an important first step. So.
Thanks for a great grand rounds. My question relates a little bit to your denominator. So most of the data you presented, I assume, are patients who've been identified as having PAD, and that's how they basically show up. And yet, I suspect that's a tiny fraction of the burden of PAD. And we've done a great job. Somebody strains their pec in the gym and they're in the ER getting ruled out for an MI, and yet people will tolerate claudication for years. And so I guess I have a two-part question. One is the unidentified PAD patient different than the identified in some way? Do we need to identify them, and maybe we don't know that? And then secondly, if we do need to identify them, do you have strategies for screening or thoughts about how we do a better job of identifying?
Yeah, two very important related questions. I think, first of all, you're absolutely right. PAD is severely underdiagnosed. And that's probably a lot of factors involved there, both in terms of awareness, lack of awareness for providers as well as patients. So they, like you said, claudication, they think, oh, I'm getting old, I have arthritis, I'm deconditioned, things like that. And I do think that there is a huge under awareness and underdiagnosis that we need to address. I think the patient who's not diagnosed, are they different? You could argue that the patients who come to clinical attention have more severe disease, but on the other hand, I actually don't think they're necessarily that different. I do think there are disparities in terms of who gets diagnosed. So for example, in rural settings, minorities, for example, lower socioeconomic levels. So you could say that there are differences there for sure. Are there differences in who benefits from treatment? No, right? So I think at the end of the day, we know that having PAD. So as I showed you that first graph, the ABI collaboration, having a low ABI, so by definition, having PAD actually is associated with mortality. So I do think there is definitely a benefit and a reason for identifying these folks. How to do so? That's sort of the $1,000,000 question. I think a lot of the professional societies have put a lot of effort into this, PAD awareness months and campaigns through the American Heart Association, the American College of Cardiology, a lot of Society for Vascular Medicine. This is certainly, I think, really important. I think a little bit it's speaking to sort of preaching to the choir, though. I do think we need to get primary care physicians involved. We need to have direct to patient campaigning to put in on their radar that, hey, the symptoms you're having may not actually be arthritis, may actually be a disease that, you have to get treated. I think going to communities is really important. So CPC actually has a community outreach component of it where, we go to health fairs, we go to churches and schools and things like that and have health navigators to really help with screening and to then not just screen and give them a results, but then to also help lead them into the healthcare system, right? So giving them the piece of paper that says you have this, but then following up to make sure they end up seeing the doctor and end up getting the care that they need. I think this is going to be a multi-pronged effort. It's ongoing, but more work needs to be done.
Thank you for a wonderful presentation and teaching us about peripheral arterial disease. I'm from infectious disease, and we do encounter a lot of peripheral arterial disease in terms of diabetic foot infections and consequences of that. My question for you was regarding the approach that you had taken where about maximizing the lipid-lowering therapies through using a vascular team versus a usual clinical care pathway. You had shown an algorithm before about how much of lipid-lowering therapy to use. Was that algorithm provided to the clinical care partners, or this was just something that the vascular team used? Because education could be a big barrier in trying to maximize therapy as well, right?
Yeah, so if I heard you, the question was essentially related to the algorithm used by the vascular care team, and was it provided to other providers or were sort of a tool used within? Okay, sorry, just to repeat for everyone else because I couldn't quite hear. That's a very good question. So for the trial, so this was an algorithm that was designed specifically for the study, and as part of the study, because we were in a trial testing its efficacy, it was only used by the vascular care physician and the team, the clinical pharmacist who also followed it to titrate medications. I think, but that was in the setting of a clinical trial where we really wanted to have sort of a clean experiment. I think given the results, it would certainly be useful to expand this and to make it available so that people really understand, rather than titrate through A, B, C, that maybe just hitting up front hard is the way to go. Now, we also wanted to show that it worked because it is a little bit of a departure from the guidelines. So we had to kind of craft that carefully with our IRB submission, but I think it's hard to argue with the results. And so your suggestion is a very good one to disseminate that information and increase provider awareness.
Could you please comment on antithrombotic management in patients with chronic PAD or post-revascularization who are already on or being started on full treatment dose anticoagulation for other indication like atrial fibrillation and PE? How should their antiplatelets be managed in that situation? And the second question was related to the figure you showed that describe the risk factors like ABI, previous peripheral vascular event, and the age seems to have a negative association. That was a little bit surprising to me, so I just wanted to get your thoughts. It looked like increment of age by 10 was associated with lower worse outcomes.
Yeah, so I think the first question had to do with antithrombotic therapy in the setting of chronic PAD and after a peripheral revascularization. in patients who have another indication for full dose anticoagulation therapy. I think, that's a separate group that was not really studied in COMPASS or in Voyager PAD, because again, I would say in practice, I would say that the indication for the full dose antithrombotic therapy actually supersedes. You're not going to use low dose vascular dose rivaroxaban for someone, for example, who has AFib, because we know that the low dose rivaroxaban is not going to be effective for thromboembolic prophylaxis in that patient. So I do think that is a special subcategory of patient for which the other indication really takes precedent in terms of guiding your therapy. And I think for the question about the age, there was a negative, sort of a slightly negative association with ALI. Is that what you were saying? Or, okay, to go back. That is an interesting finding. I don't know if it's a sort of a result of the fact that this was a clinical trial population, maybe not fully representative of what we see in real life. Certainly age is a risk factor for PAD. It's also a risk for sort of poor outcomes. But as we know in clinical trials, we tend to have younger patient populations overall. So that may have been more of a sort of finding related to that. A good observation. Thank you.
I'm Neda Rasuli, one of the endocrinologists and diabetologists. And as you mentioned, if we replace your PAD with diabetes in all of your slides, probably will apply to us, that we have the same problem, that we have a lot of evidence-based medicine for diabetes and protection of the ASCVD, but I mean, implementation is not there yet, and small percentage. And following the question that was brought up the first time, like in diabetes, we have coordinate that probably you've seen the study from Duke that they showed if you educate cardiologists and give them a PharmD to prescribe this GLP-1 or cardioprotective medication, the rate goes higher than kind of a standard of care. But what do you think about using EHR as a prompt or algorithm, that EHR kind of prompt provider to prescribe certain medication that we have evidence-based, and is that can be as equally effective as PharmD or nurse or somebody that can do the close follow-up on patient? We always in diabetes say the more touch we have with the patient, the better you get outcome, like closer follow-up. But in practical purposes is not usually happening because of the resources. So we need to think about more innovative approaches. And I don't know if you have any idea about how we can implement using, for example, EHR or some other ways.
Yeah, so the question related to sort of a parallel situation in diabetes from our endocrinologist here. There was a study right in Duke where they were able to educate cardiologists to kind of take on scary endocrine drugs and prescribe diabetes drugs, and that did increase uptake, but maybe not cost effective. And so the question was related to, can we leverage EHR, some sort of mechanism in EHR to really help prompt providers? I think absolutely. Number one, I think you're right. The same issue is going on not just in diabetes. There are other chronic diseases where we need to really think about implementation. I think EHR is certainly an important way forward. I think Greg Piazza did an EHR sort of EPIC-based reminder study with antithrombotic therapy, and I think it can work. I think one thing you have to be careful of with EPIC pop-ups is just the sort of pop-up fatigue, where a lot of providers just sort of click a lot of boxes to make it go away. I say that as someone who sadly has done that once, maybe twice. But, I think, so that's the one thing you have to think about with that. But I think that is absolutely a great idea. I think this is going to take different strategies. It can't all be optimized. It can't all be EHR. It's going to take different strategies and different studies. So different implementation studies to test what is most effective. What do providers respond to most, right? So you could have a focus group where you actually ask what kind of pop-up would be helpful? Would it be a flow diagram? Would it be a, something that automatically populates, like here, if you want to prescribe, just click here, something to make it easier for providers. But I think, with lots of people thinking of different options and kind of thinking outside the box. That's how we're going to address this in multiple different fields.
Great. We are right at 1 o'clock, so I'll end it there. If there are other questions for Dr. Hess, please come forward. And Dr. Hess, thank you for an excellent grand rounds.
Great. Thank you very much.